بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everyone to this SSBMT webinar series. This is the second lecture that we focus on CAR-T treatment educational webinars organized by SSBMT. Today we will have excellent speaker, Dr. Osman Benyam, who is hematology and stem cell transplant consultant at King Faisal Specialist Hospital in Jeddah. And I would like also to thank SSBMT, Saudi Society of Blood and Marrow Transplantation, for organizing these events, and I would like also to thank the sponsor of this webinar series about the CAR-T treatment, Gilead Kite. So Dr. Osman, with his great experience, he's going to talk about post-CAR-T long-term toxicity and management of these complications. Before he starts, I would like to congratulate Dr. Osman Benyam and our colleagues at King Faisal Specialist Hospital Jeddah for starting their CAR-T program, and they have used the first patient, I think, last week. This is represent a dedicated team working to improve the outcome of patient from Western region and from the whole kingdom. Dr. Benyam, the floor is yours to start. Thank you.
Jazakallah khairan. Thank you, Dr. Mohsen, for the kind words, and thank you, SSBMT, for inviting me and giving me an opportunity to discuss this important topic. I just want to check. I'm sharing my screen now. It should appear for you soon. And if you can
Yes, we see
confirm.
it. Yes,
Okay.
we see it.
Okay, Bismillahirrahmanirrahim. So, Assalamu alaikum Jameen. Thanks everyone who have joined. So, I will divide my talk into a very short beginning with CAR T-cell biology. I know the learned audience will know much about it, but I think it is always a good way of starting. Then we'll discuss about the early and long-term toxicities, including CRS and ICANS, which is the early ones, how to monitor for the complications, then other toxicities such as IEC-HS, which is mainly the HLH-like syndromes, the cytopenias, the ICAT, B-cell aplasia, hypogammaglobulinemia, and infections. We will also touch upon the risk of secondary malignancies and the real-world evidence of Axi-Cel. As you can see in this table, these are the FDA-approved CAR T-cell products. And in the red box is the ones that we use for non-Hodgkin's lymphoma, which is the Axi-Cel, Axi-Cel, Brexu-Cel for mantle cell lymphoma and ALL, and Liso-Cel. And we have the myeloma CAR T-cells, Ida-Cel and Cilta-Cel. And there is a new one that has been approved for B-cell ALL, which is called Obe-Cel. And now we know that CAR T cells are basically the patient's own lymphocytes that are genetically modified with an intention to kill the cancer cell. And one quick look at the naming of CAR T cells. So Yescarta is the trade name for Axi-Cel or Axi-Captogene Siloleucel. The words Axi and Silo are randomly chosen words, and it will be different for different products. The word capta stands for CAR-T. The gene stands for the gene vector that we use. The leu stands for leukocytes, and the cell stands for cell therapy. So that's how they name the CAR-T cells. A quick look at the CAR-T cell biology. So if you look at that pink cell, which is the cancer cell, they usually exhibit neoantigens. Now, these neoantigens are picked up by antigen-presenting cells such as dendritic cells. You can see those red little dots at the end of the tails. and they present these neoantigens to our inactive T cell, which is shown in blue. Once the antigen is presented, the inactive T cell gets activated and becomes a purple activated T cell. And this is how the activated T cell is supposed to take care of the malignant cell. However, what happens in real life is many malignant cells can acquire many mechanisms to evade the attack by the immune system. For example, the cancer cells might not express the neoantigens, so they lose their antigenicity and the activated T cells cannot recognize them. Or they lose immunogenicity. In other words, they start exhibiting too many PD-L1 molecules on their surface, or release too many suppressive cytokines like IL-10, which will prevent the activated T cells from recognizing the cancer cell. A third mechanism is that the cancer cells can act on the immunosuppressive microenvironment, inviting many immunosuppressive cells which come in between themselves being recognized and the activated T cell. So what can we do if they are evading capture? There are surface antigens on the surface of all cells. We know that. So if we have a B cell malignancy, and many of them or most of them will be expressing a CD19 on their surface. And if it's a myeloma cell, many of them will be expressing BCMA on their surface. So the current FDA-approved products can be divided into either CD19 CAR T cells or BCMA CAR T cells, and you can see them shown here. And basically, the CAR T cell can bypass the evasion mechanisms and they can target the antigen on the tumor cells directly. They can also do persistence, or in other words, the cells, the CAR T cells can expand and persist in the patient's body, providing long-term T cell memory. And this T cell memory can be both the effector or the cytotoxic T cells as well as the memory B cell, T cells. The word CAR comes from chimera. Chimera is a Greek mythological monster animal combined from the body parts of a lion, a goat, and a snake. So anything that is produced by joining parts of multiple entities is called chimera. So chimeric antigen receptor T cell, which is shown in the box in the middle, is made up of parts from different other receptors. So we'll have a quick look at how this is made. You can see the binding domain, which is projecting outside the cell, is derived from an antibody. The Y-shaped antibody, you separate out one arm, then you can make it into a binding domain. And this is done because the antibodies are very good at actually attaching to antigens. The second thing is a signaling domain. You can see two separate signaling domains in two shapes, and these are derived from two separate T cell receptors. For example, it could be the first one could be CD3 zeta, the second one could be CD28, or it could be like 41BB, OX40, etc. In addition to the double signaling domain, so why do we need the two signaling domain and the co-stimulatory molecule? So one of them, this is to prevent, this is a safety mechanism so that it doesn't get activated unnecessarily and cause autoimmunity. So only if that the antigen is recognized by one signaling domain and the other one confirms that, okay, this is the one which we have to attack, then only will the CAR T cell will get activated. So it's a safety mechanism basically with a primary signaling domain and a co-stimulatory molecules. Then you have a transmembrane domain. This is like a hinge. You can see that little hinge which is starting from inside the cell to the outside of the cell. And this can move around. And this allows for easy latching of the CAR T cell receptor to the cancer cell. And once we have the CAR T, then it can attach to the red cancer cell surface protein, such as CD19 directly. Now, these different parts, they're all proteins, the signaling domain and the binding domain and the transmembrane domain. So that means the DNA code for each of them can be combined together into one strip and then delivered into a disarmed or an inactivated virus. So once you have this genetic information in a virus, you can use it to transduct the patient's T cells that's already collected and pass this genetic information into the patient's T cell. Once that is done, the T lymphocyte is forced to then express the new CAR and receptor, and it becomes a CAR T cell. Now, the CAR T cell can then directly bind onto the surface receptor on the top of the surface of the cancer cell. And you can see those dots, which are cytokines that's being released by an activated CAR T cell, which will do the killing of the cancer cell by the process of apoptosis. So the advantage of the CAR T cell is that there is no MHC molecule required. There's no antigen presenting cell required. There is no neoantigen required, and it can directly latch on to the surface protein. Once the CAR T cells are brought back from the manufacturing center, so I deliberately missed the initial steps of apheresis and sending to the manufacturing center. For example, in the case of Gilead Kite and Axi-Cel, the center is in Amsterdam, and usually it takes between 18 to 28 days for the cells to be returned back. And once it reaches the hospital, then we can start the lymphodepletion chemotherapy to the patient. So he is usually admitted. We don't usually do it as outpatient yet. And it involves usually fludarabine and cyclophosphamide given on days -5, -4, and -3. And then cells are infused on day 0. Now we will look at the acute toxicities. So you can see the CAR T cell attaching itself to the cancer cell, and cytokines are being released. So these are the cytokines which basically kill the cancer cells. Now, the cytokines that are produced by the CAR T cell can also activate other immune cells in the patient's body, such as macrophages and monocytes, which in turn, these cells also start producing cytokines. So all of these immune cells are now producing cytokines, and you can have what we call a cytokine release syndrome, which is a spectrum starting from grade 1 or mild cytokine release to grade 4, and it could be life-threatening CRS. The same process happens with the cytokines leaking into the CSF. And again, the bulk activation of the T cells and the other immune cells is what leads to CRS and ICANS. This is a toxicity timeline of CAR T cell therapy. On the x-axis, you can see the number of days after infusion of the CAR T cells. So most of the early or acute toxicities start within the first 10 days. You can see they are CRS, ICANS. Then IEC-HS stands for immune effector cell associated HLH-like syndrome. So basically it is HLH. Then ICAT, which is immune cell-associated hematotoxicity, or it's cytopenias basically. And then B-cell aplasia, hypogammaglobulinemia, and infections. The later toxicities include second malignancies, and especially in the case of BCMA-directed T cells, there are neurological movement disorders. There were many grading systems for CRS. So you can see on the left-hand side, Penn grading, CTCAE, Lee grading, and so on. But the problem was it was not uniform. You can see hypotension being in grade 2 and grade 3 in different. So it causes confusion. So in 2018, ASTCT developed these consensus guidelines with many centers, experts, and pharmaceutical companies all agreeing to this criteria. And you have CRS grading, grade 1, 2, 3, and 4. There are 3 aspects that you look at, either fever, hypotension, and hypoxia. Grade 1 is just fever without the other 2. Grade 2 is fever plus hypotension, but not requiring any vasopressors. And or hypoxia, which means in this case, it will be low flow nasal cannula, less than 6 liters per minute. Grade 3 is fever plus 1 vasopressor or requiring high flow nasal cannula, which is more than 6 liters per minute. And grade 4 is fever plus multiple vasopressors plus mechanical ventilation. As we mentioned earlier, when the CAR T cells are activated and the immune cells all release multiple cytokines. Now the cytokines can be like interferon gamma, GM-CSF, interleukin 10, interleukin 6, multiple other interleukins 1, beta, 2, 8, TNF alpha, and so on. And on the right-hand side, you can see this is a typical example of the different cytokines being released. And after treatment, so on the x-axis is the number of days. After treatment, then it settles, and within a few days, the CRS has settled. Now, what happens when there is an explosion of these cytokines? It can actually increase the space between the cells in the vascular endothelium, so it increases the vascular permeability. This allows fluid to move out from the vessels, causing third spacing, vasodilation, increased cardiac output, and so on. And it can grade from grade 1 to grade 4. There are many other biomarkers which we will look at in subsequent slides. The signs and symptoms, basically, CRS can affect multiple organs, but the hallmark is fever, hypotension, and hypoxia. And the typical onset is 2 to 3 days, and the duration is 7 to 8 days. The incidence of CRS is different for different CAR T cell products. On the left-hand side, with the yellow box is the Axi-Cel. And you can see the light blue is grade more than or equal to 3 CRS. So you could say that the CRS is between like 6 to 13%, grade 3 or more. If you look at some other products, you might have a higher or lower level of CRS. You can see the T-cell right at the end with higher amount of grade 3 or more CRS. But you can see Lyso-cel in green showing much less CRS. General principles of management of cytokine release is supportive care for mild cases. And then there is this monoclonal antibody called tocilizumab, which is an interleukin-6 receptor blockade antibody. So what it does is the tocilizumab can actually bind to interleukin-6 or the interleukin-6 receptor on the surface of the cells. So this is the mainstay of treatment for CRS. In case the tocilizumab is not working, the next step would be corticosteroids. And this can block the glucocorticoid receptors and prevent the cells from getting activated and thereby releasing less interleukins and other cytokines. And for more difficult cases, ICU admission is needed. We'll look into the treatment in detail in the subsequent slides. So are there guidelines to help us decide how to treat them ideally? Of course, there is the prescribing information that comes with the ESCATA. Then there are documents such as the EBMT EHA CAR T cell handbook, which was published in 2022. This year, we had the EU CAR T cell handbook, again published by the EBMT group, and this was edited by our own Dr. Mahmoud Al-Jaf. Other published guidelines include the NCCN guidelines 2025. There was this very useful publication in 2021 by the EBMT group, which is the best practice recommendations, which is an excellent document. And for infection management and prevention, there is the ASTCT guideline published in 2024. Again, best practice consideration. So there are multiple areas where you can get the information from, but I have to say all of them are virtually very similar, if not the same. So this is from the EU CAR T handbook, which is similar to most of the other documents, and I don't think there is much difference. If it is grade 1, treat it symptomatically. If after 3 days of fever, that means grade 1, there is still no improvement, you could try 1 dose of tocilizumab. Sorry about that. If it is grade 2, start alerting your local ICU and then still treat symptomatically, but a tocilizumab dose has to be started. And if there is no improvement within 8 to 12 hours, consider the first dose of dexamethasone in grade 2. In grade 3, we should seriously be considering about management in ICU. Then the previous treatment of tocilizumab, then dexamethasone at a higher dose, 10 milligram every 6 hours. And if there is no improvement, increase the dose of dexamethasone to 20 milligram every 6 hours for 1 to 3 days. And for grade 4, definitely the management should be in ICU. And in addition to tocilizumab, should be using higher dose of steroids. And in the case of Axi-Cel, methylprednisolone is preferred. Now, if there is a fever after infusion of CAR T-cell therapy, we should be obviously thinking about, we don't know if it is CRS or due to infection. So infective, we have to treat it as infection as well. So this is from the ASTCT guidelines. You have to start an empiric antibiotic, usually a pseudomonal beta-lactam plus or minus IV vancomycin. And if there is clear signs of infection, treat the infection and continue treating the infection. And if there is no clinical or biological or radiological evidence of infection and the patient is afebrile after the initial management with tocilizumab and so on, then you can discontinue the antibiotics and resume the bacterial prophylaxis if the patient is neutropenic. But if the patient remains febrile even after 48 hours, then the usual ID consultation and additional investigations to find out if there is a occult infection. So this is ASTCT. NCCN is virtually the same, but I just want to say that for Ide-cel and Liso-cel, they are suggesting early dexamethasone even in grade 1. And some other points of interest I got from NCCN I would like to share is there is an increased risk of GI perforation with the IL-6 inhibitors such as tocilizumab. And therefore, it is important for assessing the patient for active diverticular disease before initiating the therapy. And for Axi-Cel, you can use prophylactic steroids. We'll come to that later on in certain scenarios. And anakinra also we'll discuss about it later. GM-CSF is not recommended in the setting of CAR T-cell therapy. Once again, to remind you, the tocilizumab dosing, the dose is 8 milligram per kilogram, maximum dose of 800 milligram per dose. And the maximal dose over 24 hours is 3 doses, and the maximal dose is 4 doses during any episode. Steroid dosing is different, slightly in different guidelines, but generally you could say dexamethasone 10 milligram, to start, and it might have to be increased depending on the grade of CRS, sometimes up to 20 milligram. And methylprednisolone is used in grade 4, and in Axi-Cel that is preferred. For refractory CRS, there are other agents that we can use. For example, anakinra, tocilizumab, siltuximab, and so on. I just wanted to show you this. This is our own institutional supportive care tables. So this will be printed and and distributed and put on the surface of each door where the patient is, so that it is easy for us to refer to. Now the biomarkers of CRS. So you can see that there is a correlation between cytopenias, CRP, and ferritin, and the grade of CRS. So you can see green is grade more than or equal to 4 CRS. And you can see the ANC and the platelets are much lower for grade 4 CRS. CRP is much higher, ferritin is much higher. So they do correlate. So these are tests that you could do daily to work out if there is early onset of CRS. Similarly, PT is quite high and APGT is quite high in grade 4 CRS. Fibrinogen is significantly lower and D-dimer is high. So these are also biomarkers for CRS. There are other biomarkers which all labs might not be able to do, which is the interleukins itself, like IL-6, interferon alpha, gamma, and MCP1. I'm not sure how many hospitals do it. I know King Faisal Riyadh has access to interleukin-6 testing and other interleukin testing as well. This is a famous 2013 NEJM journal. So I think that I have a feeling it might be one of the earliest, if not the earliest case of CAR T cell infusion. And you can see when they didn't know the value of tocilizumab, you can see that the interleukins and the cytokines were very high until tocilizumab was administered, and then all the symptoms settled. Moving on to ICANS, or immune effector cell associated neurotoxicity syndrome. So this is also due to endothelial activation causing increased vascular permeability. That means the cytokines can now move from the blood into the CSF, and this causes inflammation of the brain, basically. However, it's not clear whether it is the actual CAR T cells which reach there and do it. We think it is the cytokines which are doing the inflammation rather than the T cells itself, because there have been no evidence of T cell infiltration in those people who have died of severe CRS. And ICANS can happen in the absence of CRS. So you don't have to have CRS to develop ICANS. The typical onset is between 4 to 7 days, and the duration can be from 3 to 14 days. And the symptoms are anywhere between altered mental status, aphasia, seizures, headache, encephalopathy, cerebral edema, and excessive sleepiness. And this is a 2018 ASTCT guidelines, which divides it into grade 1, 2, 3, and 4. I'll just concentrate on grade 4. So you have to do something called an I scoring, which I'll go to in the next slide. So there is an I scoring, and then the second point is depressed level of consciousness. In the case of grade 4, the patient is unarousable. Third point is seizure. So it is life-threatening or prolonged seizure more than 5 minutes. Motor findings, such as deep focal motor weakness, such as hemiparesis or paraparesis. And the fifth point is elevated intracranial pressure or cerebral edema. And this has to be detected on neuroimaging. This is how we do an I score. So the nursing colleagues will do I scoring at least twice a day. And there are 4 points for orientation, like the year, month, city, and hospital. And for naming 3 objects, you get 3 points. Following simple commands get 1 point. They ask the patient to write a sentence from before infusion, and then with each assessment, and to assess the handwriting to see if there is a change in handwriting. And then the ability to count backwards or attention gets you 1 point. So a total of 10 points. Again, the incidence of ICANS is different for different products. You can see Axi-Cel on the left, the grade 3 or more ICANS is around the 20% mark, where and T-cell is kind of similar, but in follicular lymphoma, the T-cell ICANS is lower. And if you look at Lysocell in green, it is much lower than all the other products. ICANS management general principles, mainly grade 1 is supportive care and use anti-epileptics. Then the mainstay of treatment is corticosteroids. Remember that tocilizumab has no role in ICANS management unless there was ICANS and CRS at the same time. So do not use tocilizumab in isolated ICANS. And in refractory cases, there are agents like anakinra that we can use. Anakinra, by the way, is an interleukin-1 receptor antagonist, whereas tocilizumab is IL-6 blocker. And anakinra can actually cross the blood-brain barrier, whereas tocilizumab cannot. This is from the EU CAR T-cell handbook, which confirms that grade 1 is supportive care only. Grade 2, you start dexamethasone 10 to 20 milligrams every 6 hourly. Grade 3, transfer to ICU, and then increase the dose of dexamethasone to more frequently, or use methylprednisolone instead, and treat seizures with lorazepam or other benzodiazepines. Very important to do neuroimaging, ideally MRI if you can, and you may have to repeat it if the condition doesn't improve in like 48 hours. Grade 4 is again even higher dose of methylprednisolone and manage in ICU and manage for the raised intracranial pressure. This could involve multiple measures to reduce the intracranial pressure, such as hyperventilation, hyperosmolar therapy with mannitol. There was a case in King Faisal Riyadh, I remember, where they had to do a craniotomy to release the pressure as well, but the first patient survived. From the NCCN, all I have to add is that the dosing of the steroids can be a little bit slightly different, and they have already mentioned in grade 3 to consider adding anakinra. And in grade 4, also, steroids, if not anakinra, then consider repeating the neuroimaging every 2 to 3 days. And they have also mentioned that for Axi-Cel, IV methylprednisolone is preferred. So once again, looking at the steroid dosing can be slightly different, but let's say dexamethasone 10 milligram is the key, from grade 2 ICANS onwards. And it can be replaced with methylprednisolone in grade 3 or grade 4. In refractory cases, you can use anakinra. And somebody should be checking for papilledema as well in case we are suspecting, cerebral edema. This is our own supportive measures. So what lab tests could you follow up with immediately after CAR T-cell infusion? So CRP, ferritin, we already mentioned. Interleukin-6, if you have it available, will be a useful test, but it's not a must. Many labs don't have it. CBC, coagulation, D-dimer, liver function, renal, LDH, blood gas as needed, blood cultures as needed, and tests for HLH as required. And this is a summary slide. So on the third column is CRS and neurotoxicity at the same time. So ICANS and CRS happening at the same time. Then you can use tocilizumab and steroids together. For refractory cases, so first, the established therapies, just as a recap, in CRS is tocilizumab, followed by steroids, followed by anakinra. So this is established already now. In case of ICANS, it's steroids, followed by anakinra. In case we are still not able to control, there may be experimental therapies that we can try, like the siltuximab. There are new CAR T cells with the safety switch built in. Obviously, we don't have it yet. So then we have emapalumab. That's another monoclonal antibody. Some of the TKIs can be useful based on case reports. Then etanercept can be useful. In the case of ICANS, you could actually give an intrathecal steroid or chemotherapy to kill off the T cells that have entered CSF, ATG, defibrotide, dasatinib, and cyclophosphamide. These are all emerging therapies with very limited evidence. What about monitoring of the CAR T-cell patient? So prior to the CAR T-cell infusion, a baseline neurological evaluation has to be done. Baseline inflammatory markers have to be done. And those CAR T-cell products which are at higher risk of ICANS, better start seizure prophylaxis on the day of lymphodepletion. But this is not a must, but it is one of the things suggested in the new NCCN guidelines. For example, Keppra 12-hourly for the first 30 days. Post-CAR T-cell infusion, like we already mentioned, the lab test on the left-hand side. And on the right-hand side, you can see the neurotoxicity assessment should be done at least twice a day until the hospital discharge. And, this includes the physical handwriting and the gait testing and so on. And if neurological concerns develop, we have to do more testing and monitor for CRS and neurotoxicity. After the CAR T-cell infusion, they should stay around the hospital for about 4 weeks, but they should be strictly told not to do driving or any hazardous activities for the first 8 weeks, because we don't know if there will be a late onset of ICANS development. This is to show that the CRS and ICANS can coexist after Axi-Cel. You can see the CRS starts a little bit earlier, and ICANS starts a bit later, but you can have both coexisting at the same time. Median onset, once again, for CRS is 2 to 3 days for Axi-Cel. And for the BCMA CAR T cells, it's a bit later, 7 to 8 days. And median onset of ICANS is about 5 days. And the ICANS risk is higher with the CD19 CAR T cell than BCMA CAR T. However, BCMA CAR T have a unique neurotoxicity complication, which is a late onset movement disorders. Interestingly, FDA recently has eliminated the requirement for the REMS. So this is the risk evaluation mitigation strategies that used to come with all the CAR T-cell products. FDA now believes that the safety and the effectiveness of these immunotherapies can be assured without a REMS. So I think people are used to treating the complications, and we know enough that we don't need a REMS program. Another early toxicity is hemophagocytic lymphohistiocytosis-like syndrome. So it's basically, you could see it as an extension of CRS, the other end of the spectrum, but it can happen independent of CRS and ICANS. And it's characterized by fevers, cytopenia, transaminitis, organ toxicity, coagulopathy, fibrinogenemia, and hyperferritinemia. And there will be evidence of hemophagocytosis if you do a bone marrow. And on the right-hand side, you can see most of the cytokines that are raised in CRS are also raised at much higher levels in HLH. This was the old HLH diagnostic criteria, which was elevated ferritin more than 10,000 plus 2 organ toxicities, either hemophagocytosis in bone marrow or like grade 3 or more transaminitis, renal insufficiency, or pulmonary edema. This is HLH, and the treatment, the traditional treatment of HLH was etoposide, and dexamethasone, intrathecal cytarabine, and so on. But we have realized that anakinra is an excellent agent, even without giving chemotherapy. Anakinra might be able to, treat HLH-like syndrome effectively. This is a newer criteria from a 2023 paper, but you can have a look at this paper if required, if you're suspecting HLH in any patients. You can see the criteria. It's almost the same, it's similar, but the criteria is much more extensive. Other toxicities. So this is another timeline. You can see on the x-axis 1 month, 3 months, 6 months, and 1 year and beyond. So in blue are all the infective toxicities. In orange is hypogammaglobulinemia because of the B-cell aplasia and the delayed T-cell recovery. In green is prolonged cytopenias. In purple is late neurological and psychiatric events that might happen later. There are some late immune-related adverse events and secondary malignancies that can happen later on. B-cell aplasia, infections, and hypogammaglobulinemia. So it's quite common to have B-cell aplasia, and it can be a very high percentage. In the case of Axi-Cel, it can be as high as 30%. It's an on-target off-tumor effect of CAR T-cell therapy, and it's basically a collateral damage of, some of the good B cells are also killed. So, and it can increase the infection risk. What can you do about it? You can actually measure the IgG levels monthly for about 6 months and Q3 monthly until a year. Some institutions measure this, and if it is IgG levels are less than 400, then replace it with IVIG monthly. Some institutions don't even check it, just give the IVIG infusions. Infections are a serious concern. You can see at the top of the list, anti-CD19 CAR T cells, the risk is highest with bacterial infections, followed by viral infections. So bacterial in red and viral in orange. For BCMA CAR T cells, it's more viral infection than bacterial. And the Fungal infections is relatively less for both types in blue. And the risk of infection can be increased by a number of other factors. So you might be able to predict it even before starting the CAR T-cell. For example, the type of malignancy, the lymphodepleting chemotherapy, and the number of lines used, higher CAR T-cell dose, and higher grade CRS. This is from the ASTCT paper from 2024, what antimicrobial prophylaxis to use. So quinolones are suggested starting from lymphodepletion until ANC recovery for more than 2 days. Antivirals, acyclovir and valacyclovir until 6 months post-CAR-T. And if they are suspected for hepatitis from before, you can use entecavir as well, which should be continued for up till 12 months. Antifungals like fluconazole or echinocandins starting from lymphodepletion until neutrophil recovery, and PCP prophylaxis starting from day 30 until 6 months after CAR-T. Reimmunization schedule, the inactivated vaccines can be started from 6 months after the CAR T-cell infusion, and live vaccines from after 1 year. Moving on to cytopenias. So cytopenias or immune cell-associated hematotoxicity is a serious and a very common problem. And you can divide them into early cytopenia, which is less than 30 days, prolonged cytopenia between 30 to 90 days, and late cytopenia more than 90 days. And it can be due to different factors like chemotherapy, disease, and so on. EHA and EBMT have described a grading system whereby there is grade 1 to 4 based on whether they are early or late. And for anemia and thrombocytopenia, you have to use the CTCAE criteria. Just to remind ourselves, so if you look at the red curve, the neutropenia can be defined based on whether they stay low for like more than, so protracted is more than 7 days of neutropenia, and prolonged is more than 21 days of neutropenia. But usually they should recover soon. But there are 3 patterns that we see for neutropenia. One is a quick recovery in green. You can see they recover without a second dip. The intermittent recovery is a yellow. It recovers first and then dips again. And this dip can happen after 21 days. And this is the dominant phenotype. 52% of patients have this kind of dip. And the aplastic type is the more difficult one, continuous severe neutropenia of less than 0.5 for more than 14 days. There is a scoring system called CAR hematotox, which can predict the cytopenias, and it takes into consideration the platelet count before we start the process, ANC, hemoglobin, CRP, and ferritin. And it can tell you based on these points whether it is a high risk of having grade 4 or high, prolonged neutropenia. And if you look at the different conditions based on the CAR hematotox score, you can predict that the prolonged neutropenia or severe neutropenia, who may have it. Is it important to know it? Yes, because the PFS and relapse incidence can be determined by these really prolonged neutropenia patients. And this is a management strategy for grade 1, which is ANC less than 500, less than 7 days. You don't have to do anything. However, if you think they are high risk based on the hematotox score, then you can use GCSF early. And similarly for grade 2 as well, GCSF can be initiated. So in addition to GCSF, if it, you can use like prophylactic and therapeutic, like mentioned on this chart, you can also consider stem cell boost in case of really difficult cases. Secondary malignancies. In 2023, FDA issued a safety communication about T-cell malignancies, and it is rare. It is like 19 out of, like, at that time, it was 12,300 cases. 17 of them were T-cell lymphomas and 2 were T-cell leukemias. So FDA issued a black box warning in April 24 about the serious risk of T-cell malignancies. However, there was no replication competent lentivirus detected in the CAR T-cell products before infusion or in the blood samples after CAR T-cell infusion. So we're not sure whether it is the vector that is causing it, but we have to keep following them up, and we have to report to FDA and notify the manufacturer in case a secondary malignancy is detected. But please remember, the benefit of the CAR T-cell hugely outweighs the risk of this rare T-cell malignancies. This is one of those cases just to show that after, you can see in the box, after CAR T-cell infusion, they developed this skin T-cell lymphoproliferation, had to be treated with CHOEP, and then this patient was then later taken to allogeneic transplant. Another case, so this one was Cilta-cel. This was also Cilta-cel. Also needed chemotherapy after the diagnosis of T-cell proliferation. There was a Stanford paper which showed after Axi-Cel, one patient developed T-cell lymphoma, and so it can happen with all CAR T-cells. I'll miss the slide. Keep in mind, not so much with Axi-Cel, but you can have late onset neurological and psychological events. And this is about 10%. And this is something to watch out for and report so that, our knowledge about this increases. I am aware of the time, so I'll just quickly show a few more slides and then I'll stop if that's okay, Dr. Marcel. So this is a real-world evidence of Axi-Cel safety profile. It's been used for more than 7 years, more than 20,000, if not more now. Multiple real-world studies have been performed. The important thing here is if you look at the clinical trial, the ZUMA-1 versus the real-world evidence, the more than 3 neurotoxicity, or NE grade more than 3 was 30% in ZUMA-1. It is much less in real world, 19 and 8%. And CRS was 11%, it's 8 and 2%. Similarly, in ZUMA-7, you can see it is much less in the real world, except for this one study from Israel where it showed a higher percentage. So the conclusion is that grade more than 3 ICANS and CRS are generally less frequently reported in real world evidence than in the clinical trials, maybe because we know how to manage them better. Does toxicity, as in CRS and ICANS, means better efficacy? No, that's not what we are seeing. So we don't really need the toxicity to get good efficacy. What are the strategies that can do to reduce the risk of CRS and ICANS? One is to reduce the tumor burden by giving a bridging therapy. You can consider for certain patients prophylactic approaches, early and so either prophylactic steroids in very selected patients or early and proactive management. That means no prophylactic steroids, but act quickly with tocilizumab and steroids when CRS and ICANS starts. Then management of refractory cases effectively. So I'll miss these. So this is just, okay, so there are strategies where you can do either prophylactic or early intervention. So in the ZUMA-1 trial, there were some arms. So this is a ZUMA-1 trial, 111 patients. Cohort 1 and 2 was standard management, and their grade 3 plus CRS was 13%, and grade 3 plus ICANS was 28. So 13 and 28, please keep that in mind. Then they looked at cohort 3, 4, and 6 with different strategies. Cohort 3 looked at prophylactic tocilizumab and Keppra. Cohort 4 looked at early intervention with tocilizumab and steroids, but not prophylactic. And cohort 6 looked at prophylactic dexamethasone, even before starting the infusion with early intervention. This is cohort 3, which is the tocilizumab plus Keppra. This is not a good option. Actually, things were worse with this approach. So prophylactic tocilizumab is not recommended based on cohort 3. However, with cohort 4, where they started treatment earlier, means you can see cohort 1 and 2 at the top. For grade 1 CRS and ICANS, there was no tocilizumab or steroids. But in the case of cohort 4, they started tocilizumab and steroids early, even with grade 1. And similarly, steroids for grade 1 ICANS. So they basically started the treatment one step earlier. And this led to grade 3 ICANS dropping to 13% and 0%. So CRS of 0, sorry. So in comparison to grade cohort 1 and 2, which was 13% CRS grade 3 plus, there was 0% in this approach. And grade 3 plus ICANS, instead of 28%, with the standard approach, it was 10%. So a significant reduction with this approach. And this was seen with the cohort 6 approach as well. I think I'm missing that slide, which is when they gave the steroids before as well. So I think I'll stop my talk now and I'll allow time for discussion.
Thank you, Dr. Benyam. It was a great presentation, like a marathon. You went over all complications. That is a very long presentation, I know, but it is very important, and you tackle very important points, and acute and chronic complications, and you went over all of them. So again, thank you very much. And now we can open the Q&A session. So please, if anyone has any question, you can post it in the Q&A box or in the chat box. We can also take your questions. Just maybe I will start the first question, Dr. Benya. Is there any biochemical markers that you can do before the development of CRS and ICANS that can predict the onset and the early intervention, or just you advise us to go with cohort 4 or 6? So what's your advices? And is this applicable for all type of CAR-T product or certain types of CAR-T products?
So the latest of all the guidelines that I discussed was NCCN 2025. And what they suggest is baseline checking of the inflammatory markers, CRP and, fibrinogen and, ferritin and so on. I know from speaking to colleagues that the IL-6, if you can measure, gives you probably a hint, earlier to know if that the CRS is going to develop or not. But I don't know how practical it is. But the guidelines are not suggesting, any specific biomarkers other than the routine ones that we are usually using.
And this prophylactic steroid mainly applicable to Axi-Cel, isn't it?
That's correct. So my own understanding of the prophylactic approach. So I know I got rushed at that time. Again, when you look at the guidelines, none of them are explicitly suggesting that you should or they encourage you to use it. However, they are suggesting that in select cases of Axi-Cel, you can use this prophylactic approach based on the cohort 6 studies. Now, when you compare the results of cohort 4 and cohort 6, so cohort 4, once again, for the listeners, is early intervention, and cohort 6 is actually starting the oral dexamethasone one day before the actual infusion. Both approaches reduces the toxicity significantly, and there doesn't seem to be a big or no effect on the efficacy either. So for Axi-Cel cases where you think there is a very high risk of CRS and ICANS, and also those patients with comorbidities who might not tolerate the severe CRS and ICANS and might struggle to get out of ICU if they have to go. I think we can choose on an individual case basis. But in my limited knowledge and reading, I think both cohort 4 and cohort 6 are almost equal approaches.
Yeah, in our center, we use both cohort 4 and 6. We individualize the decision based on the case. So patients who have bulky, massive disease, very frail, with high risk factors for CRS and ICANS, we use cohort 6. But those patients with low risk, we go with cohort 1 and 2. And in between, we use cohort 4. And do you think using steroids is going to affect the long-term efficacy of CAR-T?
It's a difficult question. So the classical teaching for CAR T cell therapy. So if you are doing some REMS programs for any CAR T cell, they will teach you that you should not use steroids upfront because the initial thinking was that the steroids might affect the effectiveness of the CAR T cell. Now, in real world data, we are seeing more and more that the dose of steroids that we are using doesn't seem to reduce the efficacy. But I think, there is a theoretical worry. So unless we think the risk is high, I think we should try not to use the steroids. But like you said, individualize the patient's risk and then use it that way. Whether it will affect long term, I think we are looking at a cure rate of around 50% with the beast, in lymphoma, basically. And we are not seeing it different even if you use the steroids or not. But it's difficult to say whether there are minor effects long term or not. So I think we will have to wait and see. But for the time being, as I mentioned, try to avoid unnecessary usage. But for those people who warrant it, I think it is okay to use it.
Okay, thank you very much. There is a question from Dr. Agad Al-Johari. Is asking about the use of CAR-T in AML and T-cell lymphoma. I know it is out of the scope of this presentation, but do you have any answers for that?
No, the problem with these two conditions, they are the most difficult conditions because they don't have like universal markers. And T cell for T cell malignancies, there are products being studied and they are in development. AML is a very heterogeneous disease. So if you block one pathway, the cells might go through another pathway. And it is very difficult to identify surface markers for AML cells. But with the bispecific CAR-Ts and, sometimes even trispecific CAR-Ts, maybe, we can produce effectives, if you are looking at multiple markers on the surface of cells. But for the time being, AML is going to be more difficult, but T cells, I think, is coming up.
Okay, thank you very much. Another important question by Dr. Ahmed Al-Askar about the hypogammaglobulinemia post-CAR-T. How common is it, and for how long do you monitor it, and how long does it last?
So for CAR-T, for Axi-Cel studies, it was in excess of 30%. And like many of the guidelines are suggesting, keep checking the IgG levels. Like some guidelines say every 6 weeks, some say every month, for at least for the first 6 months, and then every 3 monthly for the following months. So I think when as long as the immunoglobulin levels are low, I think we will have to continue using it at least for a year, if not longer. But if you lose the B cell aplasia, which can be measured by the flow cytometry as well. So guidelines do suggest that we do, the lymphocyte subsets to see if the B cells are coming back. And if they are coming back, then that's the point when we can stop in conjunction with the IgG levels.
Okay, thank you very much, Dr. Benyam. We reached to the end of the hour. Again, thank you very much. Excellent presentation, very comprehensive. I would like to thank all participants who attended this session. And also, I'd like to thank SSBMT for organizing these webinars. And at the end, also, I would like to thank the sponsor of this CAR-T series, Gilead Kite. Thank you, everyone, and have a good night.
Thank you,
مع
Dr. Marcel and
السلامة.
Dr. Asghar.
Thank you. Bye bye.